All right, this is anatomy. So this is just a subtle finding, so you won't probably see it from where you are, frontal and lateral projection of the chest. And the finding is on the lateral projection. So it is quite subtle. So let me bring this up and mag it up. And here is the finding. So it is this thin white line in that portion of the chest. So that'll give you a feel for where it's located on the lateral projection. And one can see that it is contiguous with one of the pleural surfaces. So by appearance, as a fissure, and it's consistent with a fissure, it would be very consistent with a superior accessory fissure. So here I'll bring up the CT. Now, of course, the CT wasn't done for that reason, but I just had the images. So here we go. We'll just go straight over to the right side. And here is the nice anatomy. We can see the accessory fissure here. Superior segment is separated from the basal segments by the fissure, right middle lobe and right upper lobe. Now this one is perhaps a little bit unusual because oftentimes, this fissure, superior accessory fissure, will go right there and you kind of have something of an X formed by the fissure. So this one has this length of fissure as well. But I think it's just a variation, a little bit of a variation on the theme of a superior accessory fissure.
Well,
but for sure, the superior segment is here, middle lobe, basal segments, and then the other segments. So just a nice example of that.
Howard, are we on the left here? Or
we're on the right. No, we're on the right. Yep.
On the right. Okay.
Yep. So a nice example of that. All right, this is kind of an interesting case. What I know about this patient is the following. The patient has a history of colon cancer. At an outside institution, he was followed for that. And these are CTs from the outside institution. And as best I know, he was referred here to thoracic surgery because of surveillance imaging that showed an enlarging opacity. So here is the opacity in question, this small guy, and that is February of last year. So I'll just give you a feel for what that small guy looks like. It's the only finding, so it's a single finding in the chest with no other findings to suggest metastatic disease from a colon cancer. Let me bring up alongside the most recent one, which is from May of this year that we have, and we can see that it is a little bit bigger. Let me try and keep that from synchronizing. So there it is. So it's slow enlargement between February and May over that period of time for a lesion like that. It's, I think, really hard to know whether it is something that is arising from pleura, perhaps even pericardium, or in the mediastinum because of its location. But it's certainly well circumscribed. It has smooth margins. Of course, it's not likely to be a metastatic lesion by virtue of its slow growth and the fact that it's there in isolation. But they took that out, and it is a thymoma. Just a typical small thymoma. So there you go. Thought that was quite cute. It's interesting that it's not quite in the central part of the mediastinum in the usual place. It's a little bit offset. But I could not have diagnosed that as such necessarily.
So Howard, it's interesting on the CT to the right as you were scrolling up and down, and I don't know if it's volume averaging, but it almost looks like as you go to the undersurface, it goes deep to the pericardium, right? Like that image below right there. Are there sagittals or anything that?
let's see what I have from the outside. I have a coronal. I was looking to see whether I have thin cuts. I'm not sure. Well, I've got something there.
Yeah, there it looks like it's more like pushing on the pericardium than actually deep to it.
Yeah, that's right. It's not clearly deep to it, is it?
Yeah, no, I think, okay. It was just the other thicker.
Yeah. Okay. So just the incidental slow growth of a thymoma. It happens. I think in the context of lung cancer screening, for example, the incidence of thymoma in a program is not super small. I think if I had a guess, I think it was around maybe 1%, something like that. Well, maybe less, but it's not uncommon to encounter them as an incidental finding, of course. Okay, this next one is a really, really fascinating case. So I'm going to withhold some information, but I'm going to show you how things evolved over time. So bear with me because it's super interesting. So here is a person with a radiograph in December 27 of 17, and a pacemaker is present. He began to get ill around that time, and I will show you a radiograph obtained. Gosh, I don't know why it does that all the time. Sorry. On the 31st, and you can see now that he is getting ill. There are more diffuse lung opacities, and his lung volumes are diminished. So an acute illness for sure. And then I will tell you that he also had a neurologic presentation and ended up in the intensive care unit on a ventilator. So let me show you now that he did have what was really thought to be a stroke, basically. So there's this area of low attenuation right here that was consistent with an area of ischemia. And I'm not going to show you, well, I don't have all the images. I have some, but he had a workup for the stroke over a period of days. And the workup included the evaluation with the neck CT, of course, to evaluate the subclavian and the carotid vessels and so on. So at that time, he was also diagnosed with a stroke, or what could be a stroke. Now, let me show you, going back, because I do have one for comparison, a CT from 2013, and then a CT done more recently. So he carries a diagnosis of biopsy-proven sarcoidosis. And if you look at the distribution and the appearance of the opacities on this chest CT, very consistent with a fibrosing sarcoidosis with upper lobe scarring. And of course, very consistent with nodal sarcoidosis with calcium. So no problem with that. Now I'm going to show you the CT that was done at the time of the acute illness, approximately. And let me make this one a little bit bigger. So I'm going to show you some new opacities that have developed that are new. You know, some are quite focal, somewhat rounded, but with ill-defined margins. Some are ground glass in attenuation. And they are definitely new from the prior one. And you can see there's also involvement of the lower lung zone. So now we have something more than just sarcoidosis, and the appearance is not really typical for progressive sarcoidosis, I don't think. So now I'm going to show you the CT that was done. Let me get my timing right here. So that's the 27th. Let me just go back to the 23rd over here. Just bear with me because this gets a bit complicated. But we have just a couple days between these two CT scans from the outside. And in looking at the 27th, I thought that some of the opacities. Just take a look, keep your eye on this one where I'm showing you for a second. In the left upper lung, look a little bit smaller, but starting to maybe cavitate. So here's one example. If you compare this little guy with something up there, the overall opacity is getting a bit smaller and it may be cavitating. But now I'm going to show you the dramatic finding, which was actually seen on the next CT, and these are just 2 days apart. So let me get those up and let me get the right window for you. And again, 1-1 versus 1-3. So look at 1-1, what's happening up here. We have more opacity in the apical lung regions here. But look at the appearance and the tremendous progression in 2 days of a lung destructive process. There's just these irregular, large, confluent cystic spaces that have developed. And if you look in some of them, you can see, for example, if you look up here, you can just see the lung is just destroyed. It's just melting away. There's a cystic space right there that has a little bit of residual tissue. So here we have an incredible necrotizing process, or maybe necrotizing is not the right word, but a process in which the lung parenchyma is just disappearing in a very short period of time. So I thought that was really interesting. So typically when I see a tremendous necrotizing pneumonia and the presentation is suggestive of infection, one would think of maybe staphylococcus, but maybe pneumocystis, although I'm not sure I've seen the cysts of pneumocystis develop so quickly. But that is really dramatic. At about this time, a bunch of antibodies positive for cocci were discovered in his CSF and in his blood. And the neurofolks started to think he had a vasculitis rather than an ischemic problem in the brain. And then he had a BAL, and now I'll show you the final result because he had a history of a travel to Arizona in December. And you can see the history there. And you can see that he had hyphae diagnosed with eventual culture for cocci. So this is a crazy case of coccidioidomycosis involving the CNS as well as the lung. I don't think I've ever seen one quite like that before, anything like that before.
Wow.
Everything else was negative in terms of infection.
Yeah, we see a lot of patients with cocci that have meningitis or have neurologic symptoms. But yeah, I've never seen one that caused this degree of, as you said, lung necrosis and destruction. And they'll certainly cause lobar pneumonia or bronchopneumonia. But you wonder still if there was some superimposed bacterial pneumonia as well.
I don't know.
But
for sure.
Also, I guess the other question is too, did he have cocci before and not sarcoid? And has he been to an endemic area before? Oh, I guess that's the other question. The other thought that crossed my mind when you said that. But
no, I think the sarcoidosis is well established. And his visit to Arizona was in December when he had the pacemaker placed there.
So, Howard, was there immune compromise? Was he on steroids for his sarcoid or anything like that?
Oh, I'm glad you asked that. I think at the time of admission, when these opacities were discovered in his lungs, they didn't know what was going on, and they did start steroids thinking maybe he's got organizing pneumonia. But I don't think he was on steroids before the onset of the acute illness. I think it was in response to getting ill. When I showed you these radiographs, somewhere in there, they started steroids. But he wasn't on it before that I know of. Before that.
Ethnically predisposed. I mean, Filipinos and blacks have a particular susceptibility to disseminated cocci.
Don't know. Yeah. But it's the kind of lung destruction where you think that maybe, you know, the enzymes like matrix metalloproteinases that can degrade extracellular matrix were just ramped up incredibly. destroying extracellular matrix, and the lung was just falling apart. And it's that kind of process is what I surmise is going on up here. Oh, I do want to show you the follow-up just out of interest. So he actually, I hope I have it. Yeah, I do. So he was actually healed. So he was treated with fluconazole, and he actually got better. And I want to show you this one because if you had this CT and you had no prior information, no prior comparisons, and saw the cystic lung disease that he ended up with, of course, you would have no real chance of discerning that this is a consequence of what happened before. Look at that. So that's in July. That's right now. Let's look at that. The lung in between looks okay.
People have looked at HIV in him, right? Have you been checked out?
They did. They did. Not HIV positive. The pneumocystis was negative. The only thing that came up and eventually was culture positive was the cocci.
Amazing.
So I was floored by that. I really was. That is so impressive. So if it's not that, I don't know what it is, but there's a lot of circumstantial evidence to indicate that seems to be what it is. All right, Jeff, those are my cases.
All right, thank you. That was a crazy case. All right, let's see, Travis or David?
Travis, you're on. I don't have anything this week.
All right, while we're waiting for Travis, I can show a few cases. Hold on a second here. Okay, so let's start with this case. Should see a chest radiograph.
Right.
Okay, so this is a middle-aged man with a history of autoimmune hepatitis. You can see he's got distended belly, small lung volumes, and this area of consolidation, maybe a little nodular in the right upper lobe. He also has an azygous fissure with a very large azygous vein, which goes with his portal venous hypertension. There's the lateral, just showing this area of consolidation. So it looks like your typical community-acquired infection. On the CT done the same day, shows that, actually, sorry, wrong scan. Let's see. There we go. Here's the CT the same day. We got this area, there's the area of consolidation, and it's got some cavitation within it, and very abrupt margins, with some, maybe a spared lobule or two around it, but again, in really one primary airway distribution in that right upper lobe. And then this large pleural effusion, which is presumably related to his liver disease. And then, which is just kind of an interesting finding, is the dilated azygous vein in the azygous fissure from his portal venous hypertension. And there's his ascites and cirrhotic liver and such. So he wasn't responding to typical organism coverage. And so eventually they were able to recover a fungus, and this ended up being Cryptococcus neoformans. Which, I usually think of forming large nodules. And this one, as you can see, as it responded to antifungal treatment, it sort of coalesced into one big cavitary mass, which you would see maybe more with Cryptococcus. But I don't recall seeing a lot of cases of crypto that were more consolidative without more, discrete nodules. I don't know if anyone else has similar experience.
No, that is really...
Yeah, and his CNS was negative. They did a lumbar puncture because they need to exclude that because of the high risk. So I guess between his liver disease and whatever immune suppression they were trying to keep at bay, he was predisposed. And he's at end-stage liver disease now, but have to clear this before they even can consider transplant. But yeah, I mean, the fungus that I think of that would look like this would be like a mucor or an aspergillus or even blasto here. Usually it's more disseminated though. All right.
Another odd fungus for today. Wow.
Yeah. So that's my fungus case. Now I've got two fun aortic cases that were shared with me by my colleagues. So This is a baby who presented at birth cyanotic. You can see some support devices in there. And I can't really comment on the lungs. Magnify this up here, but doesn't look like overt shunt physiology, but to be honest, it's been a long time since I've seen a lot of babies. But what's cool is the CT scan. So they did echo, it was abnormal. And so we're going to see a couple of things here. First, we're going to see this, there's the pulmonary artery, very large. There's the patent ductus right here. And it communicates over with the descending aorta. There's a balloon pump in at this point. But what's cool is there's a single vessel coming off the heart there, and I think it shows best on these 3Ds. Oops, I can show them. Look, there we go. Yes, single vessel coming off. So this is there's the descending aorta. So this is a type 1 truncus arteriosus. So what you have, the pulmonary artery and the aorta come off the common trunk, and I'll go back to the axial, and give rise to each of the separate ones. So this is the truncus right here, and there's the aorta coming up with its branches. You see it's a right aortic arch, aberrant left subclavian, which then communicates, and it descends on the left, and it communicates with the patent ductus there.
Wow.
Yeah.
So the aorta, so this common vessel comes off more from the right ventricle, or?
It's usually an overriding aorta. If we look at the contrast mix, in this case, it looks like it's more coming off the right in this case, because the septum's down in here. But there should be a shunt, a VSD, or an overriding aorta to allow the left ventricle to empty. But you can see the right heart's quite dilated compared to the left. Yeah, so there's I can't pronounce it. It's Dutch, Van Pra or something like that classification. There's type 1, 2, and 3. And it has to do with where the branches come off. This is the most common. Haven't seen one in a long time, but it's a nice example of that. And this is more interesting, at least I think Seth would like this case. So this is a 13-year-old who has a known aortic valve problem. And I'm just going to, I've got the echo here. I'll see how well it shows it. You can see this is supposed to be the aortic valve here, and they don't label them well, but here it is in cross section. It's too fast. I'll just show the MR images. I think these show it best. So first of all, we can see there's the aortic valve, and it has this single, you don't see the leaflets really separating, and you can see turbulent flow to and from. So we have a regurgitant valve and some turbulence. And then on these are just the axial SSFPs. You can see, let's stop you can see right there only appears to be one real cusp to that aortic valve, and I'll go up a little bit as well. Again, this thickened, irregular cusp. You don't see a normal looking valve. And so this is a unicuspid aortic valve. And then this is what I like. This is the 4D flow. So during systole, you see the red flow. This is the antegrade systolic flow. And then right after that, you see the regurgitant jet, and the red is the high velocity. So that's 120 centimeters a second. So it's quite a regurgitant valve. So now he's had this for some time. I mean, he's had it, but they've been watching it for some time, but the regurgitation's gotten bad enough that will probably need to be fixed now. I think Seth has shown us a unicuspid valve before, so I was hoping he'd be on to see it.
So Jeff, how much stenosis was part of this unicuspidity? Was it both stenosis and regurg? There
is a degree of stenosis. You see that you see the dephasing artifact right here. You see a little bit of it there, but it's more regurgitant now at this point. It's almost more of a membrane, I think, than a true leaflet. But there's not, you don't see real hypertrophy in the left ventricle with a long-standing high-grade stenosis. So it's really the regurgitant portion that's the problem in this case. Okay.
Very nice. Yeah.
So a couple aortas. Yeah, they seem to always come to the same time. All right. Travis, are you there?
Yeah, I'm here. I had a consult going on when Howard finished up.
All right, I figured.
See.
Let's see, I need to make you the presenter.
This. Give me 1 second to hide the screen there. Sorry, I just want to make sure I'm not showing anything I shouldn't before I, okay. Okay, do you see my screen?
Yes.
Yep.
So I want to start with this case. This is a kind of a question mark case. I'm curious what everyone thinks. So this is a patient who has breast cancer. And I'm going to show the old CT first. This CT is from January. And you'll see that she has a little bit of subtle reticulation and ground glass subjacent to both of her breasts. So she's had bilateral breast conservation therapy and radiation. So these, the typical scar that we see in those areas underline both breasts. And then at this point, she had a new metastasis to her upper thoracic spine. As you can see here, there's a destructive bone lesion. And so in between that study and this study, she underwent radiation to the spine as well as fusion up there. And you can see that she's developing a little bit of ground glass surrounding the spine in that area. So probably a little bit of radiation pneumonitis. But what's interesting is that on this study, there's a little bit more of this reticular abnormality underneath both breasts than there had been before. But when I show you the one from last week, you'll see now, because this is the one I saw last week, that it's clearly there's even a little bit of just consolidation in both of these areas that's progressed, from an area of fibrosis, because her radiation to her breast was a few years ago. So I'm curious if anyone has seen what I think is essentially just like a recurrence of a radiation pneumonitis when the radiation is performed elsewhere. Now, of course, we've seen cases of radiation-induced lung injury where the lung injury extends outside of the radiation field to just other parts of the lung and can give you an organizing pneumonia type pattern. But it's interesting that it just seems to be almost recurrence in the field that was previously irradiated. And I don't know if anybody else has another thought or not, but.
So Travis, did she get any chemotherapy at the same time? And this could be a recall pneumonitis from drug injury within the radiated lung field?
Yeah, I mean, I guess that's the question. It's a recall. Would you call it a recall pneumonitis? I mean, whether it's.
I've seen it in people who've had mediastinal radiation, and then they get, years like before, like Hodgkin lymphoma, I saw a case. Then the patient recurred and got some chemotherapy and developed the lung injury, but only in the treatment field.
Huh. That's cool.
So I think
David on a case.
If she got chemotherapy, or could it be because, and I don't know how they did the radiation, but if they did a stereotactic, it may be possible that some of that pre-primed lung got a little bit of dose, but it was already enough to push it over that sort of re-triggered the injury.
Yeah, the radiation, I don't know if they did just more of a conventional, if they did a stereotactic or just did conventional like antero-posterior up here, but it's certainly away from here. I guess I was going for more of like just the terminology I like recall, pneumonitis, but I'm wondering if it could just be from the radiation, because I don't think she got more chemo. I'll have to check and see. But, I think I've mentioned this concept before because it's been discussed by some of our pulmonologists, the whole idea of the abscopal effect. And this is just the idea that at least with treatment that you'll have, localized radiation therapy, then it causes a reaction in the immune system that can treat cancer outside of the irradiated field. So it stimulates a cancer treatment outside. And so some of our pulmonologists talk about like an abscopal effect of organizing pneumonia or lung injury outside of the field as well. And I think it's probably, a similar concept to the recall pneumonitis, that the immune system's already primed or that area is already injured. But yeah, I'll look and see. But I think it's probably what it is. It's some sort of just recurrence in her already injured portion of her lung. But yeah, I'll have to look and see if she got chemo. I think it was just radiation though.
So people, when people talk about recall pneumonitis, they talk about agents that are radiomimetic, the chemotherapy that's radiomimetic. and here you have radiation being radiomimetic. So I would extend the concept of recall pneumonitis to anything that's like radiation, including radiation itself. I think that's a lovely case, and I think we should extend recall pneumonitis.
Yeah, I like it. And now, is recall pneumonitis, is that a published term, or is that just what?
Yeah,
like,
that is an established term.
Travis, cool. I pulled my Hodgkin lymphoma case. Do you want me to show it real quickly?
Yeah, please show it, and I'll look up her stuff while you have control and see if she got chemo.
All right. Let's see here. So yeah, I actually have a couple cases, it turned out, and I think David has one because I saw one in here. So this was a patient who was, let's see, I'm showing the wrong screen. There we go. So here's a radiograph from a long time ago. Patient who had been treated for Hodgkin lymphoma. Here's their and then they developed a recurrence and got chemotherapy. So this was the original radiograph, I believe. And then they got treated, and this was the first post-treatment CT, and you can see starting to develop some ground glass opacity, sort of very vague looking organizing pneumonia-like stuff just in the central lungs, not much out in the periphery. And then this was 2 weeks later, and you can see it looks like, I mean, there's a little bit out in the periphery, but the majority of it is in the old treatment field.
Gosh, that's interesting. Yep.
Yeah.
So, and this was on a chemotherapeutic agent like
gemcitabine, which causes a ton of lung injury.
Got it.
Yeah, and then this is, I got to get these in order here. This was another lady. This one had spinal radiation for, I think, breast cancer. I can't remember if it's what it says on here. Lymphoma, and yeah, and whoops, I lost my totally lost my screen here. There we go. And you can see it's sort of in that, again, that same region following therapy. And then here's the correlate CT. So, you know, this is the radiation was a long time ago. This was all chemo, but the majority of that, what looks like an organizing injury, is primarily in the treatment field.
Very interesting.
All right, I'll turn it back over to you, Travis.
Yeah, that's cool.
The other phenomenon that is analogous to this is recall dermatitis. I think recall dermatitis is more frequent than recall pneumonitis. So the recall phenomenon does occur in other places like skin.
So she is on a drug that was started around the time of the radiation. It's abemaciclib, whatever this. It's some sort of, you know, this is the drug that she's on now. So it's some sort of inhibitor. So yeah, okay. So I whether it's from the radiation or from the drug, it's some sort of recall pneumonitis then. I like that term. Cool.
Yeah.
Very good. Thank you.
Excellent.
All right. Let's go. I like this one just because I was showing my residents and some of my residents this morning were struggling with this. And so, you know, I'll give you a second to look at this. I think there are a lot of findings on both the PA and the lateral radiograph, some obviously more subtle than others. Let's see, flip. So on the PA radiograph, I think we all noticed this, first of all, this extra contour here behind the heart, the medial portion, you lose the diaphragm, it's socked in. Great look for left lower lobe atelectasis. You can also notice the remaining left upper lobe looks a little hyperinflated with a little more spaced out vessels than you see on the right. And I think it's a nice example, subtle spine sign here, and then you can see the entire right hemidiaphragm, but lose the left hemidiaphragm right there. So no surprise, and also looks like in the more posterior subcarinal region, you kind of lose, or you see this mass here. And we can see this is the left main upper lobe continuum. So that's still patent there, but no surprise that when this patient went to CT, and this is the PET CT, that there's an enhancing nodule in here. What's interesting though is this was biopsied at an outside hospital, and they came in with a diagnosis of small cell carcinoma based on the biopsy. And of course, when I looked at this, I thought this wasn't really crazy about this for a small cell, thinking it looks more like a carcinoid tumor. It's enhancing, there's calcification. you see a little bit of extension into the main stem bronchus. And our pathologist looked at the cells again and just saw blue cells and said it could be either small cell or something along a neuroendocrine spectrum. And then patient underwent a left pneumonectomy because of the location of this, and it was confirmed as an atypical carcinoid, not a small cell, but just a good July case with typical left lower lobe collapse and a nice, good look for a carcinoid tumor.
You said,
I think in my experience,
carcinoid?
Sorry, David?
Travis, it was atypical, not typical?
It was atypical carcinoid. Yeah.
Cool.
The thing in my experience that folks, trainees don't get, I mean, we emphasize all the findings, but the finding that's the most important, I think, well, one of those that's most important and often overlooked is the vascular finding. So you ask, where is the left hilum? Where's the left vascular hilum? Of course, it's depressed and rotated medially, number one. And then, of course, the remaining vessels in that lung look odd because they look small and they're separated apart. I call that the diverging vessel sign. And in my experience, the vascular findings are not well analyzed.
Yeah.
Because it helps a lot to identify the volume loss.
Yeah, that's a good point too, with the left hilum being depressed and at almost the same level as the right hilum. And of course, yeah, you do have some of a flat waist sign here. I always find that more helpful in inpatients where they have acute left lower lobe atelectasis when you have another comparison to see what their heart used to look like. But you're right, that's there as well.
And the left main bronchus is pointing more vertically downward than it normally would. So I think that right.
Okay.
Yeah,
so
it's got more of
like
a J shape rather than straight across. Yeah.
Yep.
Good points. So the next one, this is kind of interesting. I saw this at the VA a few weeks ago, and and finally have an answer now, which is why I saved it. And this is the old radiograph here, and it's only 3 months old, but it's interesting because, of course, I find that all retrocardiac stuff, our residents struggle with at first until you can get them to look there. And in this case, the left side looks okay, but I noticed on this radiograph, I wasn't really happy with what we were seeing here. And this is a patient who had no prior cross-sectional imaging to compare to. And I wondered, sometimes we see varices back here or hiatal hernia. Certainly he didn't have a hiatal hernia on this prior lateral radiograph, and it looked pretty good there. So and it turns out he had some chest pain and maybe some dysphagia, so difficulty swallowing. And so we told him get a CT based on that finding. I was wondering if there could be either hiatal hernia or mass, but it turns out this is what his distal esophagus looks like, and this was done the next day. And so he did in fact have a mass there, and this turned out to be an adenocarcinoma of his distal esophagus. And I was just amazed at how this radiograph, looked, I mean, I wouldn't have called anything there. I think that's just normal, and just how this showed up over just the course of 3 months. I was kind of surprised that was what the finding, that's what it turned out to be. But you can clearly see that there's something sitting behind here in the azygoesophageal recess. So just a subtle radiograph finding, for all the residents watching, just look behind the heart and you'll see stuff a lot.
Very much
okay,
so.
Let's see. Now this one goes back a few weeks. I showed the case from UCSF of an invasive vertebral hemangioma. And I had made reference to an older case that I had shown several years ago at Emory, and this is that case. I was able to finally find it. And so invasive vertebral hemangioma it's a benign tumor of the spine, but it looks nasty. And this one looks very similar to the one I showed just a few weeks ago. You have this hypervascular thing that I think this is probably a better example because you can still see the vertical striations in the vertebral body, but you can see how it extends posteriorly and is impinging on the cord and is a very hypervascular lesion in the spine. I'll show you the MR and the CT in this case. And I think this is a nice example of just that corduroy appearance of the vertebral body. but this is one that was taken out and was confirmed to be another invasive hemangioma. Let's see, the MR, it should have typical T2 bright, as you can see in this case, and you can see how it's exerting mass effect on the canal, on the cord there. So this is the second of the two invasive vertebral hemangiomas that I've seen. So it's in the differential. When you see something hypervascular, especially patient doesn't have a history of cancer, looks like it could be a hemangioma, it certainly can look, behave like a more malignant process.
So invasive here is more just analogous to extravertebral protrusion, growth of the lesion.
Yeah, right. So aggressive like pattern with epidural extension.
Yeah.
Yeah. And this is a case report that I had from there, from before. And yeah, Howard, I think you were off the week that I showed the other one, but I had another one that looked very similar to that. It was more recent from here. And then I've got two cases somewhat related here. I will show the other one first. So this is a patient that came into referred to our interstitial lung disease clinic, and she's 78 years old. And this is the only CT we had. She has some emphysema, and you can debate whether or not it's honeycombing here, and that won't be the important part though. This was the only CT she had, and she had a bronch at the outside hospital, which was negative. And then we were reviewing this in our multidisciplinary conference, and I said that I was very worried about the appearance of her left lower lobe, just because she has all of this asymmetric consolidation and ground glass opacity here. And the pathologist had the transbronchial slides and looked at it and was able to find one cluster of atypical cells, because we were worried about adenocarcinoma. And of course, I've shown other cases, and you probably see these too occasionally, that patients get referred for interstitial lung disease that end up having cancer in there. And so at another hospital, they actually repeated the biopsy based on these findings, just given this asymmetry here and all of this soft tissue. And they redid it, and it was another transbronchial biopsy that this was an adenocarcinoma. So I think, it's more of a mucinous component with the ground glass and consolidation. And this one, she does have some underlying fibrosis, but we've seen other cases where it has been just mistaken for fibrosis when you have asymmetry, as these adenocarcinomas can cavitate or cause architectural distortion. So that one kind of sets the stage for this other one that I have,
Before you go on, could you go back to that case, just the one that you were showing, just for a moment? Yeah. Because it's interesting that there's a fair amount of material in the lumens of generations of segmental bronchi in that posterior basal segment. Now that, of course, may be a completely different process, but one does worry, I suppose, that it could be more cells and mucus getting over from the left to the right there.
Right, if she has bronchorrhea and a productive cough from this.
It's not massive, but it's interesting that there are quite a few bronchi that are filled with stuff.
And of course, we went through the discussion because this was the only time point we had. Certainly she could have had an acute pneumonia or aspirated here, but she was an outpatient, she wasn't ill. Yeah, and so those are, of course, findings that should raise alarm. And then this one, which I just saw yesterday, is even, I think this is a pretty interesting example. So this is somebody who was also diagnosed based on this CT. They had shortness of breath. And here you can see they do have a little bit of reticular abnormality, 70-year-old. He's got some faint little ground glass opacities here. But then you see in his right lower lobe that he has almost a crazy paving pattern, but a lot of ground glass. And he does have some traction bronchiectasis in the right lower lobe, more so than in the left. And so he's another one that was referred for suspected interstitial lung disease. And they thought this was probably an NSIP pattern, the outside, based on the fact that he had all this ground glass opacity here. But of course, he was eventually treated with some antibiotics, came back, and then you can see that, of course, a few months later, this is still there, and then he's got other little ground glass opacities in other lobes. And this, not surprisingly, they eventually biopsied this, and this was a mucinous adenocarcinoma as well. So in Howard, I don't see any filling of the larger airways here, but this just kind of shows this mucinous adenocarcinoma, or if you read some of the more recent lung cancer staging literature, they sometimes refer to this as a pneumonic type of adenocarcinoma. And when you have, this is undoubtedly going to be areas of involvement as well. So you have contralateral, so this is an M1 disease when you have contralateral adenocarcinoma. And you can see at this point he had undergone a surgical lung biopsy for this, because they thought this was going to, still thought that this might be NSIP or an organizing pneumonia, and were surprised when this came back as adenocarcinoma at the outside. Although I don't think anybody should be surprised based on this appearance and the evolution of it.
Mm-hmm.
Oh, gosh.
And the gross asymmetry is not very good for NSIP.
No, exactly. And it's probably that I don't know, we didn't have the surgical lung biopsy. You almost wonder if he maybe had a little, early UIP and maybe has IPF, just because he does have a little reticular abnormality and some traction, but not a lot of fibrosis. And I think that's not the most important thing in his case.
Yeah.
So, Jeff, if you can, I can prepare one more congenital that I saw this morning. If you have something, or somebody else has something they can show for now.
Let me take a peek here.
I can have it ready in a minute. I just need to hide my screen.
Yeah, I don't have anything else up right now. Well, I have something quick. I mean, it's just kind of a.
Okay, if you want to take control, then I can get this other one teed up really quick, because it's a interesting one.
Yeah, this is kind of just something. So let's see here. I'll show you the screen. So this is a there you go. So this is an old case that he's still around today, and young adult, but this is an interesting case. So this is a young child. You can see has this funny looking chest. There's some rib anomalies, and there's just an opacified left hemithorax. And this is the CT that was done about a year later, and you can see that the heart is way over here. And descended esophagus. But if you follow the trachea down, you'll see that it just it bifurcates, but then kind of ends up down in here. So actually, there is no left bronchus. This is actually branching into the right lung. So this is a pulmonary agenesis. And I came across this case. This is really old, because I saw his radiograph a while back, but he's an adult male now. So that these patients usually develop normally. It's an isolated anomaly, and the distinction is from pulmonary aplasia, where you have a little rudimentary left bronchus, but they're functionally identical. I don't know. He's some weird esophageal dysmotility. I don't know if he had some problems as a child or something. I didn't dig around too much in this case, but just a nice pulmonary agenesis. And I don't know why he had these rib fusions there or anything. Maybe it looks like a thoracotomy defect. So maybe he had a TE fistula or something when he was born.
Oh, yeah, maybe.
That would be my only explanation for that, and his weird looking esophagus. But the other lung grows. I should show the lung windows. But the other lung, you can see, develops, and this was when he was still a child, will develop normally and supply adequate ventilation.
Do you have adult imaging on this?
Unfortunately, I don't, because I came across it because I think there was I don't remember. I don't know if I saved it or not, but it looks like one lung. Mm-hmm. I'll see if I can find it again. There's one of these ones I kind of grabbed quickly on the fly. I was like, oh, I might use it for something. I may have actually shown his case before. I don't remember his childhood case.
You ready? I think you did, Jeff, because you made the point about agenesis versus aplasia or hypoplasia or something.
Okay. You ready, Travis?
Yeah.
All right. There we go.
So this is a 2-week-old who we just scanned today, and they, of course, knew that the patient had congenital heart disease and wanted just further evaluation. We can see that the patient has a right-sided arch with mirror image branching, and this is the ductus arteriosus that we'll come back to, but you can see the arch here. And so typical mirror image branching, maybe actually a a pseudo-bovine variant with the common origin of both carotids and the left brachiocephalic. And it's a right-sided descending arch. And so this vessel here, actually, the ductus supplies both pulmonary arteries, as you see in this case. And that's because there is no proximal pulmonary artery. So it's a pulmonary atresia. And you can see here that there's a large ventricular septal defect in just a single vessel extending from both ventricles. So unlike Jeff, your case with the truncus, that this is more just it's almost like TET, except you have complete atresia of the pulmonary artery right here. I mean, this would be the RV outflow tract normally. And then this is the left atrial appendage here. So it's, whether you call this the ductus or just one major MAPGA that's supplying the pulmonary arteries, obviously this has to stay open to supply the pulmonary arteries there. But what's interesting too is the airways. So the trachea is a little deviated to the left here. And when you see it come down, you'll see that the right main stem bronchus comes off. And it's interesting because it's kind of pinched between the descending aorta and this huge ductus that you have. I think it is a normal right bronchus. I think this is the right upper lobe. And then you have a bronchus intermedius here with a middle lobe and a lower lobe. And I think on the left side, you have normal branching pattern on the left. So I think there's no situs abnormality. But what's interesting too is this little thing right here that we saw, this little posterior diverticulum. I almost wonder if this is a cardiac bronchus, because it kind of looks like there's something coming off of the proximal right main stem and going inferiorly. I was wondering at first if it communicated with the esophagus, but the esophagus is all the way over here on the other side of the aorta. So I don't know if you guys, what you think that is. I think it's probably the best guess. It's just a little cardiac bronchus based on the location. But
yeah,
it's kind of,
yeah, cardiac, sure.
Yeah.
Does it ever get into?
No, it never really goes anywhere. And you can see the superior segmental bronchus in the left lower lobe right here. So I think it's just blind ending, but it's just weird because it's so medial. And the right main stem bronchus is so long just based on where the trachea is. But yeah, so this is just another arch or another congenital variant where this is a conotruncal abnormality with just essentially what you could call, or what we sometimes call a super TET, where it's tetralogy plus pulmonary atresia. So the pulmonary arteries have to be supplied by the ductus as they are in this case. So this one, hopefully they can repair, just close the VSD, create a conduit from the RV to the pulmonary trunk, and then maybe get this out of the way so that the airway isn't as compressed. But that was our interesting congenital case for this morning.
Wow.
Very interesting. Wow.
So
yeah,
that is all I have then, Jeff.
All right. Well, timing's perfect. It's just about end of the hour. Okay. Well, thanks everyone.
Great cases.
Thanks, guys.
Yeah.
thank you. Thanks for all the nice cases.